Thank you so much for the invitation. It's an honor to be invited to present in front of this distinguished audience about cardiac muscle health among women aging with HIV. As access to effective antiretroviral therapy is expanding, the global community of people with HIV is aging. And among this community, causes of morbidity and mortality are shifting. Here you see data on causes of death among adults with HIV in France, gleaned from national surveys distributed in 2000, 2005, and 2010. As is apparent, the percentage of deaths due to AIDS declined sharply over this time period, while concomitantly, the percentage of deaths due to cardiovascular diseases gradually increased. For any aging population, two major threats to cardiac muscle health include heart attack or myocardial infarction and heart failure. Myocardial infarction represents acute myocardial injury with clinical evidence of myocardial ischemia, that is, myocardial cell death due to oxygen deprivation. In contrast, heart failure represents a complex clinical syndrome resulting from any structural or functional impairment of the process by which the heart fills with or pumps out blood. What is the interrelationship between these two disease processes? A myocardial infarction may or may not result in heart failure. And moreover, heart failure may develop in the absence of an antecedent myocardial infarction. A body of research spanning nearly 20 years has highlighted myocardial infarction as a particular threat to cardiac muscle health for people with HIV. Data from a number of large epidemiologic studies conducted in North American and European cohorts and published between 2002 and 2013 highlight that among people with versus without HIV, the relative risk of myocardial infarction is in the range of 1.5 to 2. An early influential epidemiologic study on HIV-associated myocardial infarction risk was the U.S. Partners Healthcare Database study. And this study helped alert us to special considerations pertaining to myocardial infarction risk among women with HIV. The U.S. Partners Healthcare Database study furnished sex-stratified analyses, which illustrated that differences in myocardial infarction rates among women with versus without HIV were more prominent than such differences in myocardial infarction rates among men with versus without HIV. Overall, as you can see in this chart, the adjusted relative risk of myocardial infarction among women with versus without HIV was approximately 3, whereas the adjusted relative risk of myocardial infarction among men with versus without HIV was approximately 1.5. What do we know about myocardial infarction risk mechanisms in general? An important starting point is recognition that myocardial infarction may be caused by atherothrombosis, a type 1 myocardial infarction, or may be caused by myocardial oxygen supply-demand mismatch unrelated to atherothrombosis, a type 2 myocardial infarction. As a scientific community, we have greater insight into the pathophysiology underlying type 1 myocardial infarction. In type 1 myocardial infarction, as you can see in the cartoon graphic, monocytes are lured to the affected coronary artery, and they may transmigrate into the artery, take on macrophage characteristics, and engulf oxidized LDL cholesterol, becoming the foam cells that form the fatty core of an atherosclerotic plaque. When this plaque becomes disrupted, platelets contribute to thrombus formation, blocking the flow of oxygen-carrying blood across the coronary artery to the myocardium it supplies and resulting in a myocardial infarction. Thus, myocardial infarction prevention efforts to date have been focused on mitigating modifiable risk factors participating in the aforementioned processes, namely cigarette smoking, hypertension, cholesterol, inflammation, and a tendency towards clotting. With respect to myocardial infarction prevention, there has been intense interest in the salutary potential of statin therapy, based on the fact that statins both potently lower circulating LDL cholesterol levels and also exert pleiotropic anti-inflammatory effects. And indeed, the efficacy and safety of statin therapy for primary myocardial infarction prevention have been demonstrated convincingly in select patient groups, but have never before been rigorously assessed among people with HIV. As you may know, the Reprieve Trial, randomized trial to prevent vascular events in HIV, aims to address unanswered questions with respect to statin therapy as a primary cardiovascular disease prevention strategy among individuals aging with HIV. The unifying hypothesis of Reprieve is that statin therapy will prevent atherosclerotic cardiovascular disease events in people with HIV on ART who may not qualify for statin therapy based on algorithms which factor in only traditional risk factors, but who may benefit from the immunomodulatory effects of statins. The Reprieve trial to date has engaged 7,500 people with HIV on antiretroviral therapy with no known cardiovascular disease, recruited from 116 research sites globally. These participants have been randomized either to pitavastatin, a moderate intensity statin, or to placebo, and participants are being followed for on average 4 to 6 years for the development of major adverse cardiovascular events, including myocardial infarction, as illustrated here. The Reprieve trial is primarily funded by the NHLBI with significant support from NIAID as well as support from the ACTG, CAWA, and Gilead. And this trial represents the largest randomized controlled trial in the field of HIV-associated cardiovascular disease and will inform our strategies for preventing myocardial infarction among women and men aging with HIV. What about special considerations with respect to myocardial infarction prevention, specifically among women with HIV? With R01 support from NIAID, Dr. Sarah Luby and I have led concerted efforts to encourage women's participation in Reprieve through the launch of the Follow Your Heart campaign, and additionally to embed within Reprieve scientific objectives exploring sex-specific mechanisms of cardiovascular disease risk and risk reduction in HIV. Now, you may have noticed that heart failure is not the primary focus of the Reprieve trial, although heart failure events are being adjudicated as part of Reprieve. We're going to spend the remainder of this discussion carefully considering heart failure, examining why this might represent a unique threat to cardiac muscle health among women and men aging with HIV, and considering strategies to help preserve cardiac muscle health and thus prevent heart failure in this population. As previously noted, heart failure represents a complex clinical syndrome resulting from any structural or functional impairment of the process by which the heart fills with and pumps out blood. And importantly, heart failure is a disease of aging. In the United States, for example, the population prevalence of heart failure rises from 0.3% among those aged 30 to 39 to a striking 10% among those individuals greater than 70 years of age. Moreover, while there has been great progress in efforts to prevent and treat myocardial infarction, the prognosis for heart failure remains poor. Indeed, a diagnosis of heart failure is associated with debilitating symptoms, recurrent hospitalizations, and a 5-year mortality rate of 50%. 3 large-scale epidemiology studies, including 2 studies published just last year, have highlighted that among people with HIV versus people without HIV, the relative risk of heart failure ranges from 1.5 to 2. And you'll note the very strong parallelism between these epidemiologic studies focused on HIV-associated heart failure and the previous epidemiologic studies I presented focused on HIV-associated myocardial infarction. 2 of these studies were based out of US cohorts, and 1 was based out of a cohort in China. In these studies, between 80 and 100% of the individuals represented were men, and sex-stratified analyses were not presented. So what do we know about heart failure risks and presenting characteristics among women with HIV? A 2017 publication querying the U.S. Partners Healthcare Database illustrated that among women with versus without HIV, the cumulative incidence rate of heart failure was 4 times as high. Moreover, among those women with HIV who did present with heart failure, a striking 71% presented with heart failure with preserved ejection fraction, or clinical heart failure in which the left ventricular ejection fraction is greater than or equal to 50%, whereas 29% of the women with HIV who presented with heart failure with reduced ejection fraction, clinical heart failure in which the left ventricular ejection fraction is less than or equal to 40%. For women with HIV, why does the predilection to heart failure with preserved ejection fraction matter? For one, heart failure with preserved ejection fraction and heart failure with reduced ejection fraction have different driving risk factors and different pathophysiology. As is illustrated in this schematic, heart failure with preserved ejection fraction may be characterized by increased left ventricular pressures and associated right-sided congestion, such as ascites and edema. Heart failure with preserved ejection fraction may also present with inability to adequately augment cardiac output with associated exertional fatigue and dyspnea. A second reason why the predilection to heart failure with preserved ejection fraction among women with HIV matters is that heart failure with preserved ejection fraction is more challenging to diagnose than heart failure with reduced ejection fraction. The diagnosing clinician must rely on history and physical coupled with subtle cardiovascular imaging findings and must also exclude other causes of dyspnea. But the most important reason why the predilection to heart failure with preserved ejection fraction among women with HIV matters is that heart failure with preserved ejection fraction is intransigent to medical therapy, and this is in contradistinction to heart failure with reduced ejection fraction. Here in blue, you see represented trial data illustrating that a number of pharmacologic agents, including beta blockers and antihypertensives which block the RAS pathway, reduce the hazard ratio for death or heart failure hospitalization among individuals in the general population suffering from heart failure with reduced ejection fraction. By contrast, in red, you see illustrated trial data reflecting that none of these pharmacologic agents reduce the hazard ratio for death or heart failure hospitalization amongst individuals in the general population suffering from heart failure with preserved ejection fraction. Thus, when it comes to cardiac muscle health among women with HIV, efforts to prevent heart failure, particularly heart failure with preserved ejection fraction, are paramount. In order to best identify ways to prevent heart failure with preserved ejection fraction, we need to work backwards from heart failure with preserved ejection fraction to conceptualize the pathophysiology upstream of this late-stage established disease manifestation. Taking our first step backward, we note that a key precursor to heart failure with preserved ejection fraction is diastolic dysfunction. Diastolic dysfunction is defined as pathologic behavior of the left ventricle during diastole with abnormal filling related to impaired relaxation and/or distensibility. And among patients with diastolic dysfunction, 2% per year progress to heart failure, and typically heart failure with preserved ejection fraction. One piece of good news is that diastolic dysfunction is modifiable. Taking a next step back, we recognize that an important contributor to diastolic dysfunction is myocardial fibrosis, or increased myocardial tissue collagen volume fraction. In the healthy myocardium, the myocardial structural space is comprised of 75% cardiomyocytes and 25% interstitium. But with myocardial fibrosis, we see increased collagen deposition, resulting in myocardial fibrosis, which may be diffuse, as illustrated here, or may be focal, as in a scar. With respect to prognosis, myocardial fibrosis predicts the development of diastolic dysfunction and relates to the extent of diastolic dysfunction. And this is an intuitive finding because the fibrotic myocardium cannot properly relax or distend. And like diastolic dysfunction, myocardial fibrosis is modifiable. Another important contributor to diastolic dysfunction is myocardial steatosis, or increased deposition of lipids within cardiomyocytes. Myocardial steatosis also predicts the development of diastolic dysfunction and relates to the extent of diastolic dysfunction, and this finding is also intuitive because a fat-laden myocardium cannot properly relax or distend. And like diastolic dysfunction and myocardial fibrosis, myocardial steatosis is modifiable. Taking our final step back, we see that traditional cardiovascular disease risk factors, as well as heightened systemic inflammation or immune activation, may be expected to contribute to diffuse myocardial fibrosis. Myocardial infarction may contribute to focal myocardial fibrosis, but we'll put that point aside for the moment. Meanwhile, traditional metabolic risk factors and the athesis to ectopic fat deposition may be expected to predispose to myocardial steatosis. Among people with HIV, heightened systemic inflammation or immune activation, as well as metabolic dysregulation, may be expected to drive this pathophysiologic cascade towards the development of heart failure with preserved ejection fraction. As is well known to this audience, even individuals with HIV that is well treated on antiretroviral therapy continue to have heightened systemic inflammation and immune activation, possibly related to ongoing low-level viral replication, viral co-infection, and/or microbial translocation. Moreover, metabolic dysregulation is relatively common among people with treated HIV, including individuals with established lipodystrophy, but also among people who do not have overt lipodystrophy. Indeed, physiology studies have confirmed that among people with versus without HIV, the extent of myocardial steatosis is increased, and the prevalence and extent of myocardial fibrosis is increased. Moreover, a meta-analysis of 11 clinical studies illustrated that diastolic dysfunction is very common in people with HIV, observed in up to 43% of asymptomatic ART-treated people with HIV. Where are the knowledge gaps? These studies were conducted in all male or predominantly male cohorts, and sex-stratified analyses were not provided. Thus, it remains unknown which are the most salient mechanisms of HIV-associated cardiac muscle dysfunction among women. Examining risk factors upstream of heart failure with preserved ejection fraction, what kind of cardiac muscle pathology might we expect to see among women with HIV? First, let's consider traditional cardiovascular disease risk factors. In high-resource regions, women with HIV tend to have a relatively high burden of traditional metabolic risk factors on par with those of men with HIV. And moreover, community-based studies suggest that women with HIV may be less likely than men with HIV to be offered prescription medications targeting equivalent coronary heart disease risk factors. Next, let's consider systemic inflammation and immune activation. Intriguingly, women have a uniquely robust innate immune response to HIV infection as compared to men. Among women versus men, HIV infection of plasmacytoid dendritic cells results in a more robust interferon alpha response and upstream interferon-stimulated gene upregulation. As a clinical corollary, levels of several circulating biomarkers of systemic immune activation and inflammation of relevance to HIV-associated cardiovascular disease are highest among women with HIV, next women without HIV, and next men with and without HIV. Let's also consider BMI. Recent data from Dr. Sarah Barris and Dr. Grace McComsey have highlighted that among women with HIV versus men with HIV, there are greater increases in BMI upon ART initiation, and this is seen across all substrata of baseline CD4 T cell counts. And finally, what about a tendency towards ectopic fat deposition? Among women with HIV, there appears to be evidence of advanced reproductive aging, which may be highly relevant to ectopic fat deposition. Anti-Müllerian hormone is a hormone which may be useful for characterizing reproductive aging. This hormone is produced by ovarian granulosa cells, and levels of the hormone drop to undetectable a few years prior to menopause, and actually predict age at menopause in select populations. Anti-Müllerian hormone may thus serve as a molecular biomarker for ovarian reserve, with low levels reflecting reduced ovarian reserve or progressive reproductive aging. Here in these data from the large U.S. WISE cohort study, you can see that among women with HIV versus age-matched women without HIV, levels of anti-Müllerian hormone are lower. In general population studies, reproductive aging has been shown to favor ectopic fat deposition, for example, in the viscera and the liver. So reproductive aging amongst women with HIV may be very relevant, indeed, to a tendency towards ectopic fat deposition. Cognizant of all these parameters special to women with HIV, MGH cardiologist Dr. Tom Nealon and I set out to try and characterize mechanisms of HIV-associated cardiac muscle dysfunction, specifically among women. Over the past 3 years, we recruited from the greater Boston area women with HIV, aged 40 and above, with no known cardiovascular disease, and women without HIV with no known cardiovascular disease matched on age and body mass index. And these participants underwent cardiac magnetic resonance imaging as well as cardiac magnetic resonance spectroscopy, two non-invasive cardiac imaging techniques which allow for quantification of diastolic function, myocardial fibrosis, and myocardial steatosis. The women also underwent detailed immune and metabolic phenotyping. Through our study, we found that women with HIV, as compared to women without HIV, had evidence of increased diffuse myocardial fibrosis as reflected in the MRI measure of extracellular volume. We next sought to identify upstream systemic immune correlates of myocardial fibrosis among women with HIV. We focused our attention on circulating monocyte subsets, cognizant that circulating monocytes may be recruited to the myocardial structural space and there transform into macrophages, which may promote in situ inflammation and fibrosis. In our study, we did not find differences among women with versus without HIV in the percentages or absolute numbers of these monocyte subsets. However, we did find that among women with versus without HIV, inflammatory monocytes more robustly expressed the CCR2 receptor, which may be expected to promote honing to the vascular endothelium in pursuit of its ligand MCP1. Moreover, and of greatest interest, we found that among women with HIV, the degree of CCR2 expression on these circulating inflammatory monocytes related to the degree of myocardial fibrosis and also to the degree of diastolic dysfunction. So while causality cannot be established by this cross-sectional study, our findings do intimate a plausible immune mechanism which might be contributing to heightened myocardial fibrosis among women aging with HIV, and that's a mechanism which entails enhanced recruitment of inflammatory monocytes from the circulation to the myocardial structural space. Through our study, we also found that women with HIV, as compared to women without HIV, had increased myocardial steatosis, or intramyocardial triglyceride content, on MR spectroscopy. And we also found that women with HIV, compared to women without HIV, had reduced diastolic function, as reflected in two MRI measures, left atrial passive ejection fraction and circumferential diastolic strain rate. And moreover, among the women with HIV, there was a strong inverse relationship between the degree of steatosis, or fat in the heart muscle, and the degree of diastolic function, meaning more fat in the heart muscle, worse diastolic function. We then sought to identify upstream metabolic or hormonal correlates of increased myocardial steatosis among women. And in our cohort, we did not find a relationship between myocardial steatosis and either chronologic age, measures of adiposity, or measures of lipid or glucose homeostasis. But we did find that among all women, myocardial steatosis increased along a continuum of reproductive aging, which was characterized by both menstrual history and levels of anti-Müllerian hormone. And this finding resonates with our observations as clinicians that the menopausal transition influences women's deposition of ectopic fat. So pulling it all together, how can we use insights on heart failure risk factors to conceptualize strategies which may be applied to preserve cardiac muscle health among women and men aging with HIV? If we take each of these upstream risk factors by turn, we can then consider strategies such as cigarette and drug abstinence, antihypertensives, anti-inflammatory therapies, lipid-lowering therapies, anti-hyperglycemic therapies, diet and exercise, and therapies which might affect fat distribution, such as tesamorelin or estrogen. In HIV endemic regions, we may also want to consider testing strategies targeting some additional risk factors. For example, opportunistic infections, micronutrient deficiencies, pollutant exposures, and mitochondrial dysfunction, possibly related to older antiretroviral therapeutic agents. Dr. Tom Nealon and I are testing two of the strategies I mentioned as means of preserving cardiac muscle health among women and men aging with HIV. With R01 funding from the NHLBI, we're testing statin therapy, and we're hypothesizing that the myocardial protective effects of statins may be mediated through reduction of lipid levels, as well as through dampening of systemic immune activation and inflammation. And to test our hypothesis, we're leveraging the Reprieve Trial study design and operation and co-enrolling 130 Reprieve participants from 3 U.S. regions and from Cape Town, South Africa. And participants are undergoing cardiac MRI and MR spectroscopy, as well as metabolic and immune phenotyping at baseline and 2 years after randomization to statin or placebo. We're also testing a second strategy, and that is strategy with growth hormone releasing hormone, which is a hypothalamic hormone. You may know that in the United States, growth hormone releasing hormone analog is FDA approved for treatment of HIV lipodystrophy. And indeed, among people with HIV with ectopic fat deposition, this hormonal therapy has been shown to improve the lipid profile, to reduce visceral fat and liver fat, so 2 other ectopic fat depots, and to dampen systemic immune activation and inflammation. So it's possible that this therapy may have favorable effects on the progression of myocardial steatosis, as well as cardiac function among individuals aging with HIV. More data on these and other strategies to preserve cardiac muscle health among women and men aging with HIV will be forthcoming in the next few years. In terms of review and synthesis, myocardial infarction and heart failure represent threats to cardiac muscle health among women and men aging with HIV. The Reprieve trial will determine whether statin therapy reduces atherosclerotic cardiovascular disease events, including myocardial infarction in this population, and the Reprieve Women's objectives will assess sex-specific mechanisms of atherosclerotic cardiovascular disease risk and risk reduction. Heart failure risk is increased among women and men with HIV, and the women with HIV who develop heart failure tend to develop heart failure with preserved ejection fraction, for which no effective treatments exist. Thus, we must continue to study upstream mechanisms of HIV attributable heart failure risk among women, for example, processes contributing to myocardial fibrosis and steatosis, with a communal goal of intervening early to forestall these processes and preserve cardiac muscle health in this population. Thank you very much to this audience, to the conference organizers, to the NIH, and to the women who participate in our clinical studies and trials.
Markella, great presentation.
Thank you.
I'm very pleased to see, though, that you are really highlighting it's just not in HIV, it's really across the board. Mm-hmm. Women are underrepresented in clinical trials. Mm-hmm. And I think we've all got to try to make that message loud and clear. Okay, so any questions? So, over there, Robert.
Markella, as one of the three cardiologists in the room, thanks very much. And, really elegant talk. From a clinical perspective, how much do you think undiagnosed and untreated hypertension in women is a factor with respect to fibrosis? And the second part of the question with respect to steatosis is how much is insulin resistance a factor in steatosis?
I think that one of the community-based studies that I presented showed that women with HIV may be less likely to be offered therapies targeting established cardiovascular risk factors. And that's really important because if the risk factors are present and they're treatable, they need to be treated. If they're untreated, then certainly the hypertension will contribute to fibrosis, and certainly undiagnosed, untreated dysglycemia will contribute to steatosis. So I do think that it's important as a means of prevention that we modify traditional risk factors, but I think that we're in the early stages of trying to tease out of all of the things that I highlighted that may be contributing to fibrosis and steatosis, which are the ones that are driving fibrosis and steatosis the most among women with HIV, so that we can also intervene on those processes in addition to treating traditional risk factors.
So, any other questions? Yes.
I just wonder, in your research or what you've reviewed, how you deal with cultural issues surrounding modifiable risk factors. Pregnancy is often a time when women can really focus on their health and control their HIV disease. And I've been surprised when I see former patients a couple years out and they've gained 60 or 70 pounds, and I tell them they look marvelous, and they say, yes, I'm so happy I gained all this weight, and I'm really not so happy. But I think in certain communities there's a real delight in overweight.
I think culturally sensitive care is really important, and yesterday we spent a lot of time talking about how patients and providers really need to work together as a team. I think an important starting point, though, with respect to cardiovascular health and healthy aging among women with HIV is outreach that heart disease is actually a risk, because I think a lot of women do not necessarily perceive it as a risk. And so a starting point is just sharing information. And in yesterday's opening session, we talked, Lucy brought up the important point that we don't want research to create fear in people. We want research to be presented as a starting point for discussion and as an opportunity. And so one of the reasons I like to focus on upstream risk factors when I talk about risks is because by doing research to highlight the upstream risk factors, we create opportunities to prevent diseases, which once they are established are very hard to treat. So I think that's a goal that we share.
So I think that's a very good way and a really fantastic.
Thank you very much.
Thank you very much.